All right, so to introduce our speakers tonight, we'll start with Professor Jenny May. So Professor May brings a wealth of experience to the role of National Rural Health Commissioner. She's worked as a rural GP for more than 35 years across Western Australia, Northern Territory, New South Wales, and also a little bit in rural Canada. Is that right?
Yes, 2 stints in rural Canada, rural British Columbia.
Amazing. And with probably 2 decades or more years of experience in health education and lots of research expertise in health workforce matters. She's also, I'm not sure if you're still the director of the University of Newcastle department in Tamworth, but still based in Tamworth.
Yes, most certainly.
Amazing. Professor May also received the Order of Australia in 2016 for her significant service to community health in rural and regional Australia as a GP, to professional medical groups and to education. Professor May started her role as the National Rural Health Commissioner just on the 2nd of September. We are extremely fortunate to have her tonight. And really looking forward to be able to collaborate and to support her in her role. So thank you so much and welcome.
Thank you very much.
Professor Jared Watts, I don't think he's been able to join us. I've sent him a text message. He's had his flight delayed twice. I'm still going to introduce him because we had a little bit of a backup plan. He's recorded a video for us for the first question, and hopefully he'll be able to join us tonight. But if not, and if there are any questions that are for Professor Watts in particular, please send them through because we'll be keeping an eye on those. So Professor Watts is currently the head of Obstetrics and Gynecology in the Kimberley of Western Australia. He's the Director of Obstetrics and Gynecology for the WA Country Health Service. He also works as a Medical Coordinator and Associate Professor for the University of Western Australia Rural Clinical School. He's completed other studies in medical administration, international public health and tropical medicine, and he's worked internationally in several countries, including Nigeria, Cambodia, Laos, Sierra Leone, and Syria. Professor Watts is really passionate about First Nations health and rural medicine, and he's been a fantastic ally for us in rural obstetrics down under, as well as for all rural generalists across both FRANSCOG training and rural generalism. So when he comes on, we will welcome him, but please let me know if there are any specific questions that are for him, because I'm sure he would be more than happy to answer them. Next we have Dr. Dan Halliday. So Dr. Dan Halliday is the President of the Australian College of Rural and Remote Medicine, or ACRRM. Dr. Halliday is a very experienced rural generalist obstetrician, and he's the Medical Superintendent at Stanthorpe Hospital in rural Queensland. He's also been the Director and Deputy Chair of the Rural Doctors Foundation and the State Counsellor for the Australian Salaried Medical Officers Federation of Queensland. Dr. Halliday's been an amazing mentor, facilitator and supervisor for lots of doctors in training, and I'm sure many of them would be able to support me when I say he's a wonderful mentor. And it looks like Jared has joined. Is that right, Elise? Let's see if I can find Jared.
It looks like he has joined. I'm not sure if he's joined on the plane, en route anywhere, but welcome to speak up, Jared.
I have to make him co-host, otherwise he won't be able to. Let me see if I can find him. Here he is. There we go.
Great, thank you so much. Sorry about that. I just heard the end of it, so thank you.
That's all right. Welcome. And Dr. Halliday, welcome. Are you? Yep, you're all good.
Yeah, all good. Thanks very much, Marion. Thanks for inviting me, and looking forward to the discussion tonight.
Thank you for joining us. It's a huge privilege. And last but very much not least, Dr. John Hall, who's based in Weipa, who reopened the birthing unit in Weipa, which we all know is no small feat. He's overseeing the medical services throughout the Western Cape York, and he joined the Torres and Cape Hospital and Health Service team as the new Director of Medical Services Western. Dr. John Hall is also a former president of the Rural Doctors Association of Australia. I'm very proud to say that I have been on the board for RDAA and have been able to work with Dr. Hall, which is a huge privilege. So thank you so much for joining us, Dr. John Hall.
Thanks, Marion. Great to be here, and thanks for putting it on, and congrats for all the work you've done with RODU.
Thank you so much. So that we can allow as much time as we can for questions, we might launch in. For this first question, I was hoping that we could give an opportunity to each of our panelists to be able to answer this first question. I think that we can all agree that Australia has a very good health system, but we continue to strive to make it better. About a third of Australian mothers live outside of a metropolitan city. The geographical vastness of Australia presents challenges in maintaining accessible, timely care for birthing people and their families. So to start discussions tonight, I want to ask each of our panel members, what do you think we should prioritise in bettering our rural birthing services for patients in rural and remote Australia? Professor Jenny May, do you want to go first?
Thank you. I guess what I'm going to do is be quite brief, but to say clearly my personal wish and that of the National Rural Health Commissioner role would be that ubiquitous, equitable access to birthing services no matter what your postcode is. So very clearly the balancing act here is about what those birthing services look like and how proximate they are to where people live. And clearly in a country like Australia, the answer to that question is going to differ, partly due to geography and partly due to resourcing. But what would be my wish? My wish is genuinely that equitable access, timely access to rural birthing services for all those that live outside a metropolitan area.
Yeah, definitely agree. I think that's even though that's a very short, sharp statement, I think that's what we're all aiming for, and it's something that I know isn't going to be easy. It takes a fair bit of work to be able to implement that concept. Professor Watts, do you want to go next?
Sure, I was actually hoping you could just play my video because I got to practice it a couple of times beforehand, but now I have to do it off the top of my head, don't I? And I think I asked for no wet season and better aeroplane transport in the first one as well, but it got me there just a few hours late. So look, I think that, forums like this is so important, and it's time to go out on a limb and really do something. So I'm going to sort of talk about something a little bit more, maybe not a little bit more controversial. And I am really passionate that I think that we always get told, like, let's hope that our rural services live up to the tertiary hospital. Like, hopefully we get there, they're as good as a metropolitan. But I actually think that our rural services need to be better, and we need to be leaders in the way that maternity care is done, because, we're not near the big tertiary hospitals. Our patients have more social determinants, health issues. There's a lot more pathology in country areas. We have, such a high percentage of our precious First Nation families as well in rural areas. So look, I would love to see us really move the way that we do obstetric care to team-based care. So these terms such as midwifery-led care or GP-led care or specialist-led care, I think we should move into team-based care. I think this is really important in rural areas because, just the disappearance of one or two midwives, one or two GPs from some of these small towns because of politics or us trying to guard each other's, workplaces and everything, sort of these fall over. And I've seen this happen in lots of small towns. And the other thing is birth trauma is, so important now. And I think that, when you're meeting people for the first time in labour as one of your care providers, that's so important. But in small country towns, we really, do need to do this. So my thing is to let's, lead the maternity world, lead the obstetric world in rural areas, look at team-based care. We can come in and out and provide the best care. And we're one big happy team rather than, trying to fight, because we know that obstetrics and GP and midwifery, we've all, except for us people here on the webinar who love each other tonight, but, it is a bit of an issue in some of our places and definitely the tertiary hospitals. So let's lead the way in rural care and have this one big team that's happy.
Yeah, well said. I completely agree. Next, I want to speak. I want to introduce Dr. Martina Mende, and I'm so sorry for not doing it earlier. So Dr. Martina Mende, we're also very, very, very lucky to have you tonight. Dr. Martina Mende is a GP obstetrician who is working in a GP-led maternity unit in Queanbeyan. Martina holds a master's in public health and has pursued further education in medical administration and leadership alongside medical education training. Her work includes training rural GP obstetricians and GPs in sexual and reproductive health. And Dr. Mende is also on the board of of RANZCOG, and she's the chair of the RANZCOG Associates, both Procedural and Advanced Procedural Committee. It's a very important role, and she's been a very great advocate and a great voice for us in RANZCOG, as well as Professor Watts. So welcome, and I'm very sorry for that oversight on my part. But Dr. Mende, I'll ask you to tell us what you think our priorities should be for the future of rural birthing.
Great, thank you, and thanks everyone for having me tonight. I'm coming from Ngunnawal and Ngambri land. So me and Jared obviously sit on lots of committees together because he stole my team-based care comment that I was going to make, which we talk about quite often. But I would actually like to go back to my GP roots and think about all of life care. And I would actually like to see, so far we've talked about maternity and birthing, but I would actually like to see this actually extended to reproductive services. I think it's really important that women have equitable access to maternity and birthing services, but also that they have equitable, safe and timely access to contraception and abortion care services as well, which is something that is deeply inequitable within our rural services in Australia. So I would like to think about, you know, a lot of us are GP obstetricians or GPs by background. We probably also have some rural specialists here, but I would like to think about the whole woman and their family. And I will just do another little plug for team-based care, because I deeply believe that no one clinician can provide everything for one patient and their family. And so we have been talking a lot about team-based care and moving away from, you know, the one clinician model of care. And I think that provides greater support for clinicians in rural areas as well.
Yeah, well said. I think that concept is going to continue to surface tonight, so we'll flesh that out as we go. Dr. John Hall, what do you think our priorities for rural maternity should be?
I just love that we're having a conversation about how do we make rural birthing services better, and we've gotten past that they should happen at all. And that's fantastic that we've got multiple services that have reopened across the country in the last 5 years. And there seems to be a national and statewide trend towards that. So I think it's fantastic that we're here talking about how do we make them better. I've got three main priorities. I think the first one is having nationally consistent standards along the lines of the National Consensus Framework for Maternity Services, which is being worked on. I think this is really important, and it goes to holding states to account to actually be motivated to and deliver birthing services, but also make sure that they're highly functioning birthing services. So I think institutions like the National Cabinet and the old COAG, you know, in the past, they've created KPIs for health services, like the number of antenatal visits for Indigenous women and those types of things. And I know that they're very sensitive to those sorts of KPIs. So I think there's potentially a role to expand some of that so that we've got bigger levers to actually bring the states all into line and to make sure that people do accept and work towards the fact that these birthing services are a basic human right and that they need to be delivered, and that we need to be working towards making sure that they're safe and effective and functional. As Jared said, you know, aiming for better than Metro. And, you know, I've always said, and you've heard me bang on about the fact that our historical data, there's multiple published studies that show that our outcomes are actually, in fact, better in the published data, and that there is no correlation between size of birthing unit and safety. In fact, it's an inverse correlation in most of the studies. So I think we do it better, and we need to make sure that we sing that from the mountaintops. Often that gets challenged. People don't always believe it, but at the end of the day, it's real. The second priority is models of care, and I'm not going to go into detail because Jared and Martina have well articulated that, but I think we need to work on a brand here. We need to look at something that is punchy, like rural generalism or some sort of generalist model that encompasses all of the players, all across all the disciplines. And I think we could brand something that was effective. I know the term collaborative is a dirty word, but we could talk about working alongside each other and supporting each other, nobody leading, everybody working, working to the top of their scope and contributing to the care for the women. I think we can get there. And I think we've got an opportunity to brand something that's rural specific. Many of the models of care that have been articulated and studied to date are very metro-centric, and they've been studied in metro areas. So I think we've got an opportunity to brand something rural. And finally, it's about maintaining our skills and maintaining our throughput. I think we need to do something about making sure that we have adequate throughput in our birthing service. So looking at strategies to increase our numbers, whether that's marketing, working on the safety, making sure that the community knows that it's safe and that it feels safe. And also looking at things like increasing the throughput in our theatres so that we keep our theatre staff, our theatre nurses, our GP anaesthetists with a throughput, and they feel confident and competent as well. And I think there's things like increasing our visiting specialty services, increasing the scope and the range of things that are done by visiting specialty teams to support the team. So I think in the interest of time, I'll leave it there, but they're my three main priorities, and it's really exciting to be part of this.
Yeah, excellent priorities, Dr. Hall, and I hope we're going to have a bit of time to be able to go through each of those three. They're very good points. Dr. Halliday, what do you think our priority should be?
Thanks very much, Marion. And listen, if I can sort of toe the company line a little bit, I think to start off with, I'd like to reflect that the comments tonight probably actually do share a lot with the new ACRM vision in terms of healthy rural, remote and First Nations communities through excellence, social accountability and innovation. And of course, that's a change from ACRM in terms of, right doctors, right skills, right place, in terms of the feedback that we've had from our members to make sure that that the college it has a wider remit going forward, and certainly the ability to actually ensure that our communities and particularly our maternity services are able to have that access to care, and that's one of the key outcomes, obviously, that the ACRM has within its strategic plan, is to look at ensuring that access is to high quality, continuous, comprehensive care close to home, looking at social determinants, looking at the education and the continuing professional development that actually underpins a lot of the supports that we need as professionals and our colleagues in our rural and remote areas. And so I think there's a lot of that myself and the college definitely would like to promote. A little comment, if you don't mind, regarding the concept of multidisciplinary teams and reflecting on the document that was produced through the Office of National Rural Health Commissioner, and I had a chance to chat to Jenny about that the other day in terms of the Nayabar Gadan statement, which was actually signed off in about June, July last year, and so that's an opportunity to review that in terms of how we work together as teams, and then of course lead on that as to how we can take that forward. And it's really good to hear those thoughts expressed tonight.
Yeah, great. Thank you, Dr. Halliday. So I'll move on to the next question, because I think it sort of has been mentioned a few times already. But one of the great projects that have come about through the Commonwealth, or with the help of the Commonwealth Department, is the National Consensus Framework for Rural Maternity Services. Now with the release of the second edition soon, it sounds like. For a bit of history, if participants haven't heard about this before, the proposal for a National Consensus Framework for Rural Maternity Services grew out of a symposium on birthing services in small rural hospitals, which was held in Alice Springs in 2005. I was still in high school back then, but it seems like a lot of the themes are still sort of things that we are working on. The symposium was organised by the Rural Doctors Association of Australia, RDAA, and ACRM, with funding from the Commonwealth Department of Health and Ageing. RDAA subsequently secured some funding from the department to develop a framework in collaboration with the College of Midwives, with ACRM, with RANZCOG, and the National Rural Faculty of RACGP, and with Rural Health Workforce Australia. So Professor May, I might start with you on this question. I've found certainly in my pocket of rural Australia that although there's huge support at a national and a Commonwealth and a college level, there seems to be some challenges still at a state and a local level. What advice would you have for those of us who are needing assistance in implementation strategies or principles outlined in the consensus framework? And what measures are in place to have robust oversight of the function, the staffing, the funding, and the activity of current rural maternity units in order to actually prevent further closures?
Oh, what a good question. And obviously week 3 in the job, I will give you the best that I can give you. And that is that I think the first and important piece in this is that, thank goodness, that the framework exists. The framework has been redrawn, and it is a testament to Professor Ruth Stewart and to the collegial approach of many of the people actually on this teleconference who came and brought that together. And I have to tell you that it is still in draft and it is still in progress. And the reasons for that are the reasons that we've just talked about in that last question, which is that there are differing approaches to what team-based care looks like. There are differing definitions and concerns about continuity of care and continuity of carer, and there are different interpretations. Now, I would actually see that as a strength of the framework rather than a weakness, but clearly we need to get agreement and consensus with the industry players who were involved in developing the framework. So as part of that process, a number of the issues that are absolutely key and, if you like, required the framework to be redrafted, because it was a good framework in 2006, but it wasn't implemented, and it wasn't implemented uniformly in a way that we could, I guess, work and build on. So the opportunity then arose to revisit it, and that is because there was a problem. There was a disconnect in the implementation of the accreditation, the management, the workforce, all the things that we've talked about today. So my approach is to get this document to consensus and then get it commended. Now, your question is absolutely on point. Where will the framework go? To whom is it directed? And who is going to be given the imprimatur or take it up to respond? And I'd say to you that that continues to be a difficult space, because the states, in essence, are the deliveries of much of the intrapartum maternity care that occurs, city and country. The Commonwealth has responsibilities in terms of funding, both directly in terms of MBS, but also block funding to small hospitals, a variety of other funding sources. So how do we get them all to sing from the same song sheet? How do we get the sort of teeth or performance framework in whatever arrangements are made between the Commonwealth and the state that actually speak to those standards and the requirement to deliver and support and co-design maternity services that work for the communities that we're working in? I do believe that the team is the secondary issue, but I do absolutely affirm, and it is wonderful for me to hear the comments so far about that, trying to keep the focus off who's the lead in the process and who will be the default continuity or where the funding will go. We must be flexible about that. We must think about what, from the patient or the woman-centred approach, what the team is that we can grow in whatever area we are. So I'm heartened to hear already that willingness to actually engage about that. And I think, like Dan does, that the next piece of work is around exemplars of what that teamwork looks like, and then trying to think about what the funding basis is for the way that we do teamwork. So I think that's the up-to-the-minute approach. Let's hope that we can get the document to consensus and commended by the end of this year. That's my goal. And as I said, it's a document that we all own. It's an industry-developed reference document. What we've got to do is now get it into government in a way that it can create the sort of accountability that we're seeking. And thank you for having me on, because in fact, my job is to listen, and it is gold for me to listen to the views of not only the panel, but also of your members about how we can possibly pull this framework to the spot that we all think it needs to go.
Yeah, absolutely. And like you said, Professor May, 3 weeks into the job, you've hit the ground running. We're all here to support you. It's absolutely not an easy thing to be able to achieve, implementing this or holding, states accountable and, translating this into something that is woman-centered. But we are here to collaborate with you. And yeah, we absolutely understand that this is not an easy task by any means. Dr. John Hall, I wonder if you can answer this question. It was a very long question, but would you like me to repeat it, or do you?
I've been following it and read it, and Jenny's helped as well, like unpacking the question. Look, I think this is a great question. At the end of the day, you can have models of care, you can have policies, and what it comes down to is how you interrelate within your teams. One of the things that has helped us in WEPA is the relationships that we've built with the midwives and the consistency of those relationships and our other team members. The fact that we've got a good critical mass of GPAs and GPOs and other supportive SMOs. And also we've been fortunate to have a support from the district management, from the TCHHS and the like. But I think a lot of this comes down to relationship. And no matter what your model's called, no matter who they say should lead or who, what the model's labeled, at the end of the day, if you're working really closely together, you can deliver a team-based approach where there's mutual respect and where people are encouraged to work to the top of their scope. So I think part of that goes to that when you've got functioning relationships and functioning teams, the labels matter less. The labels matter a lot when you don't have that. And sometimes that's impacted by things like fly in, fly out workers, people that are coming from different models. I've found that sometimes people coming from other countries where they've got models that, for instance, don't have GP obstetricians working in this space, or have got models that are more midwifery only, then that can be really challenging. You people coming into a model that they don't understand. But even there, I think one of the biggest ways to cut across that is through relationships, and that's building trust, mutual respect, working together, and backing that up with deeds and actions and support, not just words. So I think that's built us some strengths. We're working in a model that's technically a midwifery group practice, but it's working more like a team-based approach, in my view, and it's working really, really well. And, we've already delivered some good outcomes. So I think for me, like on the micro level, it's about relationships. At the macro level, it goes to what I said in my first answer. I think there does need to be some and KPIs that the states are held to in this space, so that they know that they've got to deliver this. So I think that's important, because so many of the HHSs across all the different models, you've got different states with different models, but a lot of them have models where different health districts are very autonomous, and they can be so autonomous that they can choose to do this or not. And the only way that you're going to get all of those health districts to agree and toe the line, I think, is with nationally consistent standards and some national KPIs that will actually make them want to do this, because they do often, as I said, they're quite sensitive to national standards, like the hand washing, like the Aboriginal number of visits, and those types of things are being really effective. So I think we need something like that in the rural space to hold the health services to account. And then at the micro level, we need to work on relationships, critical mass of teams, and working together with mutual respect.
Yeah, well said. Someone has put in the chat, I think they've articulated this quite well, but in a team-based approach, there still needs to be someone that has to assume overall responsibility for the care provided. And ultimately, this usually does fall to the GPO or to the Franz-Cog who is coordinating the care. So maybe Dr. Mendy, can I get you to sort of give us comments on what you think would be helpful if to be able to have that reflected in the actual workforce at a local level? How can we achieve that?
Oh, that's a really good question. So I think that when we're talking about team-based care, it is about working together, and the person who wrote the comment, there does need to be a care coordinator. So I think that you're right, it often does fall onto the GPO or the Franz-Cog in that case. But I think that certainly, as John was pointing out, it's a lot about working on relationships, and also I think structures within team-based care models, so that we've got policies and checkpoints in place so that it's safe for the patient and also really safe for the clinicians as well. So I certainly think that there's ways to structure team-based care models where you have a care coordinator who coordinates that care, but with that collaborative approach from all the team members.
Oh, great. I'll leave this open for a second. Either Dr. Dan Halliday or Professor Watts, if you have any comments about this, jump in.
Yeah, I'll go first, Marion. I think so. Coming from a point of view, ensuring that the woman is the centre of our care, and the focus, and I think that the information that we provide, obviously on the background of the woman's understanding of the care that is on offer, the relationships that the care providers have, and that model of care that is available is actually really important, because the health literacy, particularly in our rural and remote communities, is somewhat limited. And of course, we've got that layer of cultural issues, particularly in regards to our First Nations women who obviously have other preferences, within the whole context of women's business as well, that we need to be very cognizant of. So I think there's a lot of those issues that we certainly need to be very aware of. However, I think there's something that we may not necessarily have actually identified. Yes, as a cohort of GP obstetricians, we actually have a very valuable position to play within delivery of care in our rural, remote and First Nations communities, and that's actually to work with our other general practice colleagues to ensure that they are supported and valued to provide the best care that they can, either in that sort of early antenatal stage, before the general sort of care and other referral mechanisms actually kick in, but actually also in the postnatal phase, and to make sure that they do feel that they can reach out to us and actually and get that support, whether or not it's from a GP obstetrician or a traditional specialist, Franz-Cog, role. So I think we actually have quite a lot of power, I think, as a group, and we may not tap into that all the time.
Mm-hmm. Yeah, well said. And I think the challenge does present itself when we have to provide some sort of framework that has that flexibility to be contextualized to each region. That definitely is not an easy thing to do. Professor Watts, I think your region of Australia does it very well. And you have a lovely hybrid model that seems to be quite woman-centered and promotes that continuity. Do you want to talk to us about what's working well in your region?
Yeah, look, I think that one big factor that we always don't like to talk about, but it is true, is the finance, and we all have to, make an income. And, I have the privilege of looking after, 18 different hospitals that have, it seems like 18 different ways of doing things. And I find that the units that have the finances are set up really well because everyone's salaried, or, there's fees for, whoever's involved in the care. There's so many less issues. So if I have a very complicated patient, I have a midwife come in and sit in with me with that consultation. If I've got a patient who's under the MGP all risk model, they come and sit in the consultation, and sometimes they can sit in with the GPOs and we can learn off each other. And so I really think that, looking at models of funding is so important to take away any sort of risk of that coming into the equation when we're trying to provide patient-centered care. So whether that's between specialists and GPO or between midwife, I think that's something that we really need to think about and how that affects our patient care.
Yeah, that's a great point. Because I think that there is a little bit of conflict that arises when we don't have that salaried model, and sometimes GPs are doing unpaid work, or are stuck doing something that shouldn't have taken as long as it did, but it has, and it makes it quite difficult to sustain sometimes. I'll move on to the next question, but please come back to this one if you feel there's anything else that you wanted to add. We're going to pivot slightly to the college and the training arena. I know that I'm preaching to the choir, but we know that there is a very important mutual respect that's needed between all members of the rural birthing team, from very skilled rural midwives to our rural generalists with procedural skills to consultant obstetricians and gynecologists. There continues to be reports of deeply ingrained perceptions of one member holding greater authority or importance than a more rural or remote colleague. And there is still a number of clinicians who view rural colleagues as the less skilled, less desirable, more unsafe. And trainees being told things like, either you're too good to be wasting your skills as a rural generalist. This is either in O&G training or in GP training, or the opposite, where they're told, actually, you're not good enough to work somewhere rurally. So I believe that these views start in the training space from as early as university, and of course into college fellowship training as well. So the question is, how are our training curriculums working to shift this very archaic culture of generalism and rurality being inferior for current and future doctors, leaders, and administrators as well? Being a sort of training question, I might ask Professor Watts to start with this one.
For sure. It was quite funny. Only last week, a patient came into my room and started to ask me about a rash on her leg, and I think I stood back a little bit, and she realised that I was getting a bit uneasy. It's like, don't worry, I'll go and see a real doctor next week. So I think maybe with the patients you won already, that the rural generalism that they can do everything is quite important. But look, this is a huge issue, and I think that a multifaceted approach is the most important thing. I think that we all know the famous Judith Gardner, who has stood up at the college for so long and actually fought a little bit for GPOs to start with, and so much that now whenever the board or a curriculum or a document the college comes across, I think everyone no longer has to be asked how is this going to affect the rural thing. It already is actually there, and there's some really big things such as we've now got a rural FRANSCOG training program that Martina helped design the curriculum, because so many of those skills are so important, and hopefully they'll be working with GPs. So look, I think it's going to be a few things. So it's going to be right from day one, and it's very privileged to be in the rural clinical school where our students that come out get to see rural generalists at the best, and they get to see them run between the labour ward and put in a chest tube in DD, and then they come sitting with me, and I'm quite boring because I don't leave that room quite often. So I think exposure is really important. And another thing is even in the RMO days, we are seeing Judith has once again started where as well as just having a supervisor with your associate pathway, I still call it the DRANSCOG myself, going to have mentors as well who are rural GPOs out there where you can do it. And I know WA flying a flag a little bit has even got some funding from the government to actually, while you're an RMO, go out and see what a GPO looks like. And then back on my favourite hobby horse of finances, I don't normally talk about money so much, but I'm so, it's good to see that, hopefully other states like Western Australia, now rural generalism in the new agreement is seen as a specialty, pay exactly the same. It's fantastic to sort of see that side of it. And I think we need to fight for that as well, just so people don't see it as inferior because there's less money, less prestige or something like that.
And Jared, sorry to continue to put you on the spot, but specifically within FRANSCOG training, do you think that there is still a perception that those who go rurally are the ones who are less skilled? Is it still seen as second rate?
It's sort of interesting. Like I was actually told that when I, was going, oh, don't go rural because, you will lose your skills and everything like that. I think you learn different skills, and that's what I sort of tell the fellow trainees now. But I can also tell you that the reason that RANZCOG did start the FROGS program that we're doing, which is the Rural Generalist Specialist Obstetric Pathway, is because when we did ask people why they didn't go rural, people didn't feel prepared enough, because I think it is actually now seen that the skills that you need to have. Generalism is you do need a larger skill set. So I think that we are changing, or you guys are actually changing, which is fantastic, because the 6 months of the FRANZCOG trainees spending in the country is a minimum. I think they are seeing the amazing skills, and then we come and knock on your door because I've heard a heart, it's not going lub dub. I have no idea what to do now, but you get the rural generalists do. And so I think that FRANZCOG trainees are seeing that, and definitely from a college board level, we are definitely hopefully that is in the curriculum. And I've seen my fly in the college flag here again, but come October, November, Martin, you'll know there is a constitutional change in RANZCOG as well, that the GPOs will actually be recognised in our constitution to be able to vote on matters that affect them. So I think that some of the battle is being worked, but there's a lot more to go. But hopefully we can work together to get it over the line.
That's wonderful. And yeah, huge thanks to you and to Dr. Martina Mendy and to Dr. Judith Gardner, who have done some amazing work within the college to change the tide. We really appreciate it. And we thank you for being our voice. I'll leave it open again. I don't want to put anyone on the spot. Does anyone else want to speak to that question? Go ahead, Professor May.
Oh, look, I think just two things. I think it's a real thing, and we've really got to take it on. And it is two things. It's geographical narcissism and it's generalism. It's a double whammy, and I think they probably have slightly different solutions, but together they're a significant problem that we need to overcome. I do think that there is starting to be some recognition in medical schools that particularly the path of rural generalism is now seen as far more attractive. And I do think that the recognition piece that we're still working on and pretty hopefully close to landing in the not too distant future is another really positive piece in that puzzle. But I think, and we alluded to it earlier, I think rural generalism is certainly on the up in terms of both being seen as attractive and being seen as giving significant meaning. And many of our Gen Z trainees are looking for being able to give meaning, and it is increasingly important. But I think the rural bit is still a problem. So I'd say to you that rural general practice is still got a problem. All right, rural generalism, we're getting there, but we're going to need to think about the rural general practice piece, like we're going to need to keep focusing on the rural specialist piece. And there are champions, and obviously Professor Jared Watts is one of them, and that's fabulous in ONG. Matt Coleman has made a huge difference in Western Australia in terms of psychiatry, and he's just about to put out a paper on generalism in specialism, so generalism in specialist colleges, and I think that will be really useful in starting to again raise the profile of generalism, which will go part way to supporting some of our regional specialist colleagues and giving them the status and the platform that they need within their colleges.
Yeah, absolutely. Dr. John Hall, go ahead.
Just quickly, like on the issue of safety, I think there is a real problem with a lay opinion, and within our colleagues as well, a continued lay opinion that what we do is less safe. And I've had trainees and medical students say to me, I don't have a third backup anaesthetist, therefore what I'm doing is less safe. We don't have a NICU, therefore what we're doing cannot be as safe. We don't have an ICU, therefore this can't be as safe. And I think what this requires of us as colleges, ONG is probably one of the most evidence-based specialties in medicine, with its long history of being very evidence-based. But I think we need to present the evidence of our safety. Like, we know it's safe, and there is good data to show that we're safe from a perinatal data and an outcomes point of view. And I think we need to be reporting this back to our trainees. I think that needs to be built into the curriculum, that they're actually studying their own models of care. They're understanding why their models of care are safe. I mean, for all of us here, like we wouldn't work in a model of care if we genuinely thought we were providing inferior care to our communities. But I think I've come across this time and again where colleagues, specialists, rural trainees, other people have this lay opinion that just by nature of where we are and the resources that we have, that we are providing an inherently less safe service. And the evidence doesn't support that. And I think we need to be teaching our trainees this so that they know and they've got the comfort in knowing that they're going to work in a system that can produce very safe and effective outcomes.
Yeah, absolutely. Dr. Mende, go ahead.
I'll just follow on from John's comment because I was about to make a similar comment. And I think part of that, John, is you mentioned the layperson's opinion about safety, but I think that it also goes into the hospital administration as well. So I think that we have a significant leadership problem within hospital administration. As doctors, we're busy being clinicians, and actually over the years, we've seen less and less leadership involvement within the hospital levels. And I think what we need to see is a resurgence of medical practitioners, particularly generalists, being involved in decision-making in hospitals, and that can be both metropolitan and rural and regional hospitals, looking at that evidence and actually having a evidence-based view around scope of practice and safety, as opposed to a more gut reaction, so to speak, about what is safe and what rural generalists can and can't do.
Yeah, absolutely. Dr. Halliday, go ahead.
Yeah, thanks very much. So I think, following on from all of that, there's probably not much extra to say, but if I can take a step back, so Jenny and I attended the Medical Deans Conference at the end of last week. From my point of view, attending that conference over the last 2 years, I've seen a significant shift, firstly, in terms of supporting general practice in terms of the undergraduate curriculum, but then also the extent of having a focus of rural as well. And of course, looking at how those opportunities are starting to come by, where that discussion with medical students can actually happen on the ground. And then, of course, there's greater opportunity then to actually look at how they translate into a pre-vocational space, so as interns and RMOs, and actually have a much more supported and facilitated pathway, as you reach and go on to fellowship training. So I think there's definite progress which is happening. There's a definite realism that generalism, is the way forward to make sure that we actually have a sustainable health service, and that is starting to permeate through the university sector. As much as the government is actually starting to discuss the financial levers in terms of how it does look to increase its Commonwealth supported placements, the discussions that the government is actually having with the colleges right across the board, from the general practice colleges to the non-GP specialty colleges, in terms of the funding and the levers and mechanisms to ensure that generalism and rural practice is actually going to get the spotlight and the funding that it needs. So there's actually a lot of sectoral stuff happening, and it just, we need to actually keep it progressing now as well.
Yeah, absolutely. If I take it sort of to the next stage, if moving on from the training phase, in terms of upskilling and maintaining our our expertise in some of the procedures that are perhaps not as high in volume in some of the rural and regional areas, this is a question that was presented to us from the registration, but which body do you believe is chiefly responsible for providing high quality training? So for upskilling, both for our Francois colleagues as well as rural generalists, who's responsible, who should be paying for it, and how can we help to I guess facilitate that so that it's not a difficult thing to do, and it's part of our journey, I guess, as rural clinicians.
Is this open?
Yes.
Yeah, okay. All right. So my view on this, obviously in terms of You know, our CPD homes, you know, of course, you know, that's, you know, and that's a choice, you know, in terms of someone, you know, whoever, you know, chooses their CPD home to be maintained with. However, there's a lot of funding that attracts, you know, obviously the upskilling, and certainly the procedural training grants are quite supportive. The issue is getting access to the leave, of course, from that point of view. So therein lies the opportunity to actually address some of the geographical narcissism, and for rural generalists, you know, GP obstetricians to actually have a specialist as a consultant, you know, RANZCOGs come into our rural and remote areas. I feel that certainly in the Darling Downs, you know, having the director of O&G come out once a month to actually do a high risk clinic is actually an awesome opportunity for them to actually see the context of practice, the complexity of the caseload that we're seeing and managing in our rural and remote areas. And then actually I feel that the OJET program, which is being rolled out, you know, is another opportunity to actually facilitate that multidisciplinary learning by actually engaging midwives as well, you know, into that practice model on the ground. As much as, you know, there's obviously you know, the AIMS courses and ultrasound and all other bits and pieces, but I think delivery of the continuing professional development in practice and make it contextually appropriate is as important as the clinical attachment that we do back in the larger regional and metropolitan centres.
Yeah, absolutely. I think what you've described, Dr. Halliday, is that hub and spoke model that's mentioned in the National Consensus Framework, where, you know, some of the trainees as well as some of the O&G consultants are part of the rostering for their rural sites, so that they understand the issues, and so that there is that collaboration and that familiarity when you're calling for a transfer or calling for advice. And I think that's something that I've seen work quite well across Australia. So it's something that I think the difficulty is always in the implementation and how you make the LHDs and the administrators understand that this is very important, and being able to implement that is going to be tricky. I'll leave that question open for anyone else. Is there anything else that we think might be helpful in terms of just improving that collaboration between our rural sites and our referral centres?
I might, you know, we are trying to find some solutions here as well. And, you know, because we're all here, and I think we've got, you know, near 100 people at times, you know, one thing is that, you know, the OGET, which I'll declare that, you know, I'm the chair of that committee, but, you know, we haven't been funded again, you know, which is, you know, so disappointing, because we hear such incredible outcomes, and, you know, RANZCOGs meeting GPOs for the first time ever that they've been given advice to. So I really think that, you know, if we can push at all levels, this hub and spoke model, because I've loved the comments that are coming through. We don't have that white young male, as they sort of say, anymore. We've got, you know, problems with childcare. And so the idea that, you know, we're getting told to the GPOs just go back to the tertiary hospitals for 2 weeks every year to upskill in cesarean sections is not really, you know, there's other responsibilities, there's difficulties with that. So I think this hub and spoke, you know, where people come out for a few days would work. So trying to get that into, you know, the policymakers, you know, the politicians' ear, because that's really how things are going to work with this different workforce we've got. And, you know, things like OGET, you know, if that it seems to be working quite well, but, you know, that need to have the funding to continue it. So.
Yeah, great. Thank you. And Dr. Hall, go ahead.
Just a quick one. Part of what we applied for in getting Weeper up and running with our brief was funding for a RANZCOG employed by the TCHHS based in Cairns. That would be a known person that we would be on the panel and choose. We would fund, and they would be based in Cairns, and they would then come and do outreach to us, but they would be our go-to person, our connection to Cairns as well. So increasing the outreach, increasing the operative visits, but also having someone, a known person who we know is supportive of our context, and that got funded. So we got an additional funding for a whole specialist that sits with the TCHHS, but will be based in Cairns. And that's a great way of formalizing that relationship, so that's not just based on a personality, that it's a system funded way of maintaining a really strong connection with your feeder hospital.
Yeah, amazing. I might, just in the interest of time, I know that I've taken you guys to almost 9 o'clock, but just in the interest of time, I want to end on a question that's hopefully going to give us a really positive note at the end. This has actually been mentioned in Rural Obstetrics Down Under, but I've heard this statement many times and across lots of different hospitals. When someone says something like rural generalism, and this is, generalism within specialty training as well as within GP training, when people say rural generalism is a dying specialty, what is your response? Dan Halliday, I want to start with you.
Oh my God. All right. So listen, I just say, look at the evidence, look at the numbers. So right from medical school through to the amount of specialty trainees, has had the most percentage growth in the last 3 years. So how can it be a dying specialty? So rural generalist medicine, how can it be a dying specialty if it's actually had the most percentage increase, in the last 3 years? So whereby now you have nearly 8% of medical school graduates identifying rural generalist medicine, so not general practice, so rural generalist medicine as their preferred profession once they actually graduate. So rural generalist medicine is now 6th on the list of graduating medical students' preferences. So when you actually combine that with general practice, which the last survey I think was between 10.5% and 11%, that actually pops general practice as a whole back up against physician training. So that's that's amazing. That's awesome. The amount of interest that we're seeing, particularly in the ACRM program, we, like this year alone, we started over 350 registrars across Australia. We had to go to the government to ask for extra funding release to be able to make sure that those numbers are supported. And to give them credit, they actually gave the funding release. So that's awesome, because they know that they can't turn anyone away. And so the numbers are still tracking very good for next year. And of course, we're in discussions about, what that supply will mean to actually meet the demand gap, because of the medical workforce numbers that we're seeing at the moment. So I would say that rural generalist medicine is the area that is actually growing. It's not dying.
What about within obstetrics specifically? If I narrowed it down even more, if we're talking about generalism within rural obstetrics, and someone calls that a dying specialty or something that's struggling at the moment, I guess tell me what your response is. Should it be something that's dwindling? Is it dwindling where you are? And how do we change that?
If you looked at Queensland, for example, they filled all their training positions for the first time, I believe, this year in a few years. So the interest is increasing there. There are some jurisdictions which unfortunately aren't doing so well, and I believe that New South Wales is one of those. So I believe that, but there are other areas where the momentum towards rural generalist medicine, is such that, for example, Tasmania, the government is directing the department to find a way to make rural generalist medicine work. And so we're actually looking at key opportunities. It's not the same across Australia. We know that, but there's definitely a momentum to actually see things happen. And I think we'll get there. And I think that, it's the non-GP colleges, and certainly RANZCOG, is looking at things. Jill Gibson, she's being a Kiwi, she's actually not doing a bad job. So I think there's a lot of good intent, and I think the challenge then, and I know Rod's comment online as well, there's the intent to get things going, but we need to actually take advantage of the fact that the supervisors that are still there, we need to keep them going to make sure that we train the next generation.
Absolutely. Dr. Mende, how do we keep the supervisors going?
If I can just actually step back from the supervisors for a moment, I think that there's been some really fantastic comments actually around the changing demographics of the workforce. And Jenny, I think this is going to be one of your main challenges, because I think as rural generalists, you know, it is swings and roundabouts, and we will see that the world will realise that we need rural generalists and we can't survive without us. But we have to acknowledge this changing demographic, and we have to actually think outside the box and actually be really innovative about how we support our rural generalist trainees and doctors in communities. So, you know, I mean, childcare has come up quite a few times in the chat. Spouse, you know, the demographics of spouses and work opportunities are changing. And so I think when we're looking at rural generalist medicine, we need to actually look beyond the colleges, because the colleges can provide training and support, and we can advocate for funding. But actually we need the support of the whole communities, which involves, you know, education, childcare, and other industries within communities to actually support health professionals within communities. And I think that that's a massive challenge. So I think that that's going to take a little bit of elastic thinking on the parts of doctors to kind of figure out how we can facilitate this changing demographic of workforce. In regards to supervisors, I think that we really need to be supporting and rewarding supervisors. I think often they do a lot of hard work without much acknowledgement or reward. I think, you know, there could be greater incentives for supervisors, but also again, you know, if we think outside the box, how can we support our supervisors? How can we pay for their time? How can we, I mean, we're all here after hours, but how can we keep things, you know, within manageable work-life balance to allow supervisors to bring on the new generation of doctors, but also to maintain some work-life balance. So I think that we actually need to be thinking really innovatively and probably looking at other industries as to how to solve some of these workforce issues.
Yeah, great point. All right, I might leave it sort of as closing remarks now. Are there any other sort of things that we want to raise? We've got this amazing opportunity of leaders amongst us. Dr. Rod Martin, who's our next ACRM president, is also online. So are there any closing remarks, anything else that we think would be a really good innovative idea or model that we would like our National Rural Health Commissioner to hear about, or anyone else that I guess has any ideas that we need to sort of broaden across Australia that's working well?
Can I just throw in a slightly random comment? And those that I talked to at the National Rural Health Alliance conference will not be surprised to say that I think AI is the next big thing that we need to start contemplating, and probably the sooner the better, because what we're going to have to work out is how do we work with AI, and where does the laying on of hands become absolutely proximate and important. And I would think obstetric care is one of those, or certainly intrapartum care at least, is going to be one of those areas where the laying on of hands in a proximate and timely way is going to remain really important. So I guess my call out is to say, if we think things are going to be the same as they were 10 years ago in 10 years' time, we delude ourselves. It is my hope, my fervent hope, that we still have a distributed population that lives rurally, but the model of care that we need to be starting to factor into the trainees that we have now is going to be so markedly different that it does require us to teach and to train and to teach people how to learn, as opposed to a set of finite skills that they will use forever. So I just put that out there to a group that's obviously capable of thinking and wanting a future for rural obstetrics, that that is going to be the next big disruptor, and it's coming soon.
Yeah, absolutely. And I think it was Professor Paul Woolley who once said to me, you know, historically rural used to be second rate because of the distance to education and to, you know, and to guidelines and to libraries, but all of that's on our phone now. So we really don't have an excuse for rural to be second rate anymore. We are evidence-based. We are, you know, the ones who are providing better care and providing better continuity. So it shouldn't be a barrier anymore, and rural should never be second rate. on that note, just a plug for rural obstetrics down under, the community and the education that we've built is something that I want everyone here to obviously know about and to be part of. It's been really refreshing seeing the amount of networking that has happened amongst our group, and the education has been refreshing. I think it kind of keeps me young in a way to be able to sort of continue to talk to the trainees and to see what it is, you know, what issues they're facing, what things that they're seeing during their training, what sort of statements are being said to them about their rural intent. So please join us on the online community if you haven't already. We have been starting to collate some data on and some feedback on our education on Tuesdays. So the form for feedback for tonight and for all of our Tuesday meetings has been put in the chat. So please feel very welcome to put very honest feedback and any suggestions for improvement, because it's something that I read almost every night, and I take that advice on board. So thank you again to all of our panelists. It's been wonderful having you, and it's been a really lovely opportunity to see you all in one space. We know that this is rare and it's something we really value. So huge thanks to all of you. It's been really nice seeing all of the suggestions and all the positivity. So we appreciate it so much, and we hope we can do this again. I'll probably bother you again in 12 months' time. But yeah, any closing remarks, I'll leave it open for our panelists, and the chat is still open if anyone wants to ask any more questions. Thank you so much again.
Thanks, Mary.
Thanks again for putting it on, Marion. It's a fantastic forum, and it was a great discussion. Thank you.
Thank you for being part of it. We really appreciate it. There's lots of thanks in the chat as well. So I might call this session to a close, and yeah, hopefully I'll see you guys online, and we'll repeat this again in another year's time, if not sooner. And all the best to our National Rural Health Commissioner, who's doing a wonderful job already. All right, good night, everyone.
Thanks, Marion.
Pleasure. Thank you.